Welcome to another episode of Plastic Surgery Uncensored. I'm your host, Dr. Rady, and we are excited. Who are we? It is me and Maria, my famous producer. At any rate, we are going to do our monthly Q&As. That's right. We are answering your questions directly from social media and other outlets. You guys sent us a bunch of questions. I think people are getting smarter. I love these questions. They're getting good. Maria, I usually used to toss out a bunch of them because I thought they were silly, but it looks like almost every single question you guys sent, I said, was worthy of discussion. So we're going to be doing our Q&As, but Maria has, what do you have, Maria? You have a positive review you want to...
I have a positive review, but now I lost it for a minute there. Give me 1 second.
Okay, well, while you search for it, I'm going to go ahead and solicit for more positive reviews. Guys, come on. If you love the show and you're listening right now, I'm going to start something new. I'm going to ask you for you guys to share our podcast, subscribe, download, forward, whatever you have to do, and promise me that you're going to go write something nice about our podcast. It's good. We like it. It makes us happy. I'm going to ask you again at the end of the show, but it really does make us happy when you write something positive. Maria, did you find it?
No.
Not at all. So do you want to save it for the end?
Yeah, we'll save it for the end. That way.
All right, let's dive in as people are super eager to hear. So fire away. What's our first question?
Okay, so our first question is from SkyMel27.
SkyMail?
SkyMel27.
SkyMel. I thought it was Sky Mall. I love Sky Malls. It was just my favorite thing when I was on the airplane. Anyway, sorry, I digress. Okay, what does SkyMail say?
Plastic surgery is prominent in women in our society. Do they do it for themselves or for others?
So the question, and I thought this was one of the best questions, I almost want to hold to a segment on this, is plastic surgery is quite prominent in women in our society. Do they do it for themselves or they do it for society? And the answer is both. Of course, we do it for ourselves and we do it for society. We don't like to say the society part because it doesn't sound good. Oh, you're doing it for other people. Then if you're doing it for other people, then therefore it must not be healthy. That's bullshit. What are you talking about? You do everything for yourself and for society. Society is your community. That's your friends, your family, your environment. We are social creatures. We're not solitude creatures. We're not part of the animal kingdom where we go live in an isolate. We're not a hermit crab. So we dress nicely and we smell good and we work out and we do all those things because makes us feel good and we feel good about ourselves and it gives us a sense of elevated esteem. And then we go into society and we interact with our society at work and school and friends and intimacy and sex, and we get positive feedback, and then we go back and then we love ourselves more, and it's just a cycle. So absolutely, plastic surgery and frankly most everything else we do for ourselves as well as we do for our society. And I think that's absolutely normal and healthy. If you only did it for a loved one in an incredibly insecure relationship because your boyfriend or your girlfriend, you think they'll love you more and they don't love you, and you see they stick looking at other people with bigger breasts, yeah, that's completely unhealthy. Yeah, but on that, but that's not the question. The question was, do we do it for ourselves or society? And we do it for a mix of things. And I assure you, I haven't got my therapy degree or my psychiatry degree, but that's a normal thing. And so I'm all for it.
Okay, so this other question comes from Nancy_Gonzalez.
Nancy_Gonzalez, here's your question.
Blood clotting disorders and using Levonex after surgery.
Blood clotting disorders and using Lovenox for after post-op surgeries. It's a great question because, I just had a lady that came for pre-op and she's got factor V Leiden. That's a type of disorder that makes you clot. And she's homozygous, which means that both her parents gave it to her. So she's super at risk. And she asked me, would you operate on me? And the answer is yes. But the difference is when you are a regular patient, no pre-existing condition, and you are someone that's at risk for something, the difference is that you have to be more careful and you have to go out of your way to do more preoperative workup so that you're safe. So what we're talking about is all surgery, plastic, orthopedic, neurosurgery, general surgery, OBGYN, all surgery has a risk. One of the risks is blood clots. Blood clots are when the blood in your veins clot and become thrombosed. That is its own condition. Then there's an additional risk that blood clot in the back of your calf breaks off, the clot breaks off and shoots on up through your heart and into your lungs and causes a big plug in your lung. And that's called a pulmonary embolus. Blood clot, pulmonary embolus. Both separate conditions, related, and are at risk with all surgery, plastic surgery included. Some people, more than others, are at risk. And the bottom line is that we, at least I, and most surgeons should, treat all of you at risk, and we do certain things to treat you, irrespective of whether or not you're at higher risk or regular risk. And what are those things? One, when you walk in the operating room and you're about to be put asleep by the anesthesiologist, you need to have those compression stockings, those massagey things on your calves. Why? Because they're circulating your blood as if you were moving when you're stationary. Blood clots occur from stagnation. Stagnant. You're not moving. The blood is pooling. It's just sitting there.
That happens a lot when you fly, right?
Fly is you're sitting there and you're bent. You're bent and you're sitting there. So the key is that those leg squeezy things be on before you undergo induction, before you go to sleep, because when they give you the drugs, your veins dilate and you want that circulation to be existing before. I am a big stickler. I yell at all the nurses. There's a tendency for a lot to be going on while you're in the operating room, and they kind of forget sometimes, and they put it on later. No, 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 no. You walk in the room, the leg squeeze are on. The end. So that's one. Two, not many surgeons, but not many surgeons give you blood thinner before you begin surgery. And that is called heparin. Heparin is a type of drug. Lovenox is a type of drug. These are drugs that, depending on the dose, thin out your blood just ever slightly enough that you are less likely to get a clot, and not so much that you're going to bleed and have a hemorrhage. So many doctors in plastic surgery are afraid to give you that blood thinner in fear that you will have a bleed. But it's well documented that at the dosing we give you, it's not going to do that. That's the second thing your doctor needs to do. And the third thing the doctor needs to do is make sure that you walk immediately post-op. You need to be ambulating. You need to walk to your car, from your car to your bedroom, get up to go pee, go to the kitchen. You don't go on long walks, but you ambulate and move around so that your legs are not stagnant. What I just described to you, those three items occurs for every single patient that I operate on. If you are at higher risk, the final item is what this woman is referring to, is that after surgery, at home, you get this blood thinner that we gave you at the operating room for a few days until you get out of the woods, because your risk of blood clot is high the first week to 10 days. That's not something that's required for every patient, but people that are slightly at increased risk. The end. This is the story for everybody.
Our next question comes from Kyla Bella.
Kyla Bella sounds like Kai Bella.
Right. That's what I thought too.
Yeah. Maybe she works for the company.
Who knows? Why do I look better in my mirror than on camera? My nose looks huge in pictures.
Perfect. I love this question. It was like, we call that a lob. A lob is like when you throw a nice pitch to a guy who's waiting to just clobber the ball over the fence. So I recently put out a social media post that went viral. I was on a podcast with Sophia with an F. If you haven't checked out my podcast, shame on you. Go check it out. It was actually a really interesting podcast. But one of the things that we talked about was this idea that people are coming into my office and they're saying, hey, Dr. Vaughn, I'm here for a rhinoplasty. And I'm looking at their nose and I keep looking at their nose. I'm like, your nose is pretty goddamn good. Yeah. I know my nose is great. But let me show you a photo. What? Yeah. Look at this photo. It looks terrible in this photo. Oh, okay. But that's an image. Yeah, but I hate this image. I want you to fix my nose so it doesn't look like this. So you want me to ruin your nose because it looks good in person. So when you take a photo, it looks normal. What does that even mean? That's crazy. I'm operating for an alternative universe. Now, there's a reason for that.
What happened? How can you look good in person and then
Very simple. It's called distortion. Optical distortion. When you see yourself live, you are what you are. When you see yourself through a lens, have you ever heard of a fisheye? Mm-hmm. Have you ever heard of a wide angle? Have you heard of these different lenses? They distort the image in order to fit it into a frame. The closer you get to an image, the more distorted it gets and the more wide and round and weird it looks. So it is super common for photographs to distort your face. And that is why professional photographers, I am an amateur. I wish I were professional, working for Natural Geographic, but that's not going to happen anytime soon. Professional photographers shoot portrait photographs, portrait, not landscape, not interior decorating, portrait photographs with a certain lens, usually 85 millimeter lens, from a certain distance in order to minimize the distortion and give you the most accurate image of what you actually look like with the least amount of camera distortion. So you cannot just take a picture of your face and then be like, wow, I look ugly. Not to mention that you're animating, meaning you're like mid-frame. So do not, by any means, compare your face in a camera with anything that's in reality. Period.
But maybe it's just a matter of picking a pose that works for your nose.
Whatever. It's like, okay, you're not photogenic. Great. Thank God you're not a supermodel making a living off of being on a billboard. It's just a goddamn photo. Who cares? I look like shit in photos. I don't panic. Now, if my career and my livelihood was contingent, then they'd be photoshopping the shit out of me. So just take better photos. Try not to take mid-animation photos. Use all the filters. Who cares? Don't go operate on your face because your camera photo looks weird.
You know that I did several, at the beginning of my career, I interviewed Julio Iglesias several times.
Yeah.
And you know, if you've ever heard of the fact that he likes to only be videotaped or taken pictures from one side of his face, it's true. He is so stuck on that, and when you're going to take a video or interview or something, he has to stand in one side, only show the right side of his face. Why? I think it looks perfectly fine, but he is adamant about that.
Yeah, of course. Listen, noses are crooked, for example. Okay? Most people's nose is somewhat crooked. When your nose is crooked, then by definition, when you look from the right and you look from the left, it's different. That's a fact. That's not imaginary. Well, one side looks better than the other to you. Okay, fair enough. That's my better side. Awesome. Stand on that side. Whatever. But what I'm telling you is that it's not really what you look like. Because to the average person, you look, what are you talking about, man? You look great. Or, you know what I mean? So, at any rate, the reason is it's called optics, distortion.
Okay. The next question comes from Carol Hobeka.
Carol Hobeka?
Mm-hmm.
Right.
I have thin lip corners. Tried several doctors, but none of them are. I'm not sure of the how she wrote the question, but it says, but none of them are willing to flip the corner through fillers.
I don't really actually know what the question was, so I said for you to include it because I want to talk about a subject, whether or not it's her or not. So we all have inherently different shaped lips, right? If you look at a million lips, you'll notice some are sharp, some are short, some are fat, some are narrow, some have no angles and are just like tubular, some are very angled. Nevertheless, when you use filler correctly, you are not changing the shape of the lip. You are enhancing the shape of your lip. Did you hear what I just said?
Mm-hmm.
When you use filler correctly, you take whatever your shape is, God-given, and you volumize it. But when you add so much volume to any structure, you obliterate its definition. So what's happened is that people, and this young lady most likely has a lip that doesn't have a lot of vermilion or pink showing in the corners. And so it's small in the corners. And she's frustrated because she's going to get filler and she's unable to get the filler to change the shape of her lip. Because when she's putting it in, that area isn't plumpening up. And the reality is that that's not what it's designed to do. Now, of course, you'll see before and after photos and people like Kylie Jenner who put in 1,000 syringes, not at once, over time, has gradually changed the shape of her lips. But you don't go into a doctor's office and have one lip look and then come out with 5 syringes later and you have a different, that's just not how this is supposed to be. So the goal with filler, when done correctly, which is, by the way, fantastic, because like anything done correctly, it's fantastic, is to take your lips, which are generally thin with your shape, and give you a little bit of volume. So, it doesn't, it's a little more, enhanced or a little bit more flattering. That's what it was designed to do. Like everything that's been blown out of proportion. But nonetheless, I think her frustration is that her lips haven't changed shape.
Right. I would be careful with that. Okay. The next one comes from Aria.2249.
Aria.2249. I bet you that's her or his code to their locker or something. 22. Oh yeah, I'm going to write that down.
Okay. Can you talk about
blepharoplasty, eyelid surgery? Yeah. I mean,
eyelid surgery. Okay.
Yeah. So I don't generally like to answer these types of questions because they're open-ended. Right. And it's a whole show, right? So first and foremost, if that's your question, awesome. We have a whole show, or actually 2 shows or 3 shows dedicated to blepharoplasty, but I will give you the gist of it, or the 411. So eyelid surgery, there's generally 2 eyelids, right? The upper and lower eyelid, okay? The upper eyelid and lower eyelid are completely different. They have nothing to do with each other. They might as well be your lip and your ear. Why? Because they're anatomically different. The problems with them are different. The way we operate on them are different. The upper eyelid is relatively straightforward and is like a garage door. It just goes up and back and moves up and down. And generally, the number one issue with the upper eyelid is excess skin. I have skin above my eyelid, and it's causing me to, A, not be able to see as well, and B, when I put on my makeup, it smudges. It's ugh. So, first thing you need to know is that seldom is the issue the upper eyelid by itself. Let me repeat that. Seldom, when you're starting to be like 44, 45, 43, and you're like, shit, my upper eyelid seems a little just heavy. It's not that all of a sudden you developed eyelid skin. More times than not, it's your eyebrow that is starting to come down, and as your eyebrow comes down, it encroaches on your eyelid and gives the illusion that you've got a lot of eyelid skin. So when people come to me and they want their upper eyelids done, the first thing I do is I put my finger on their eyebrow, it's usually just the outer eyebrow, and lift it up a little bit so they can see what it looked like when they were 20. And in most instances, the excess skin that they came in complaining about is significantly less or gone. So, rule number 1, seldom is your upper eyelid by itself the culprit. And 95% of the times when I operate on the upper eyelid, I do, or I suggest to work on the eyebrow as well, because your eyelid and your eyebrow fall at the same time together. The lower eyelid, super tricky, very complicated, needs to be done by someone who does their lower eyelids. There are generally 3 issues with their lower eyelid. 1, the most common, fat bags, puffy lower eyelids. That's herniation, fat popping out. which I hate in my own eyelids. The treatment for fat puffing out is old school, remove it. New school, rearrange it. So if you heard me correctly, in the past, you just go in and remove the fat, which was turned out to be a bad idea. It makes you look hollow. The new way is to take the fat and push it around and take it from where it doesn't look good and put it where it looks good. The second issue is that we all have what's called a tear trough, or a hollowness in front of the puffiness. Hollowness in front of the puffiness, and that needs to be filled. So whether it's filler or fat, or the fat that you hate is pushed into the area you dislike. That's the sophisticated way of doing it. And the last thing is color. No, actually, there's one more after that. There's color. I got dark circles. Good luck. Makeup. There is nothing. Zero. Zilch. Nada. No bleaching. No creams. No lasers. Nothing. If you have dark skin, just cover it up. And the last item is excess skin. Wrinkly skin, which you can remove a little bit with the surgery, remove a little bit of the crepey skin under your eye, or do some kind of resurfacing. So that is your crash course on eyelids. For more in-depth conversation, check out one of our other podcasts, or maybe go on my website. We have a lot of information there. Okay.
And at the beginning of May, we had the shortcuts where we talk about a little bit of the eyes.
Yeah, we talk about lower eyelids all the time because it's a super complicated, important, edgy, it's important. You got to understand lower eyelids.
You know that I went to renew my driver's license, and when I saw the picture, my eyebrow looked like if it was drooping over, and I go, and I had not noticed it before until I saw the driver, and I said before and after, go, holy cow.
And that's when it's just, God, I can't believe I work with Dr. Raban and I look like this. Maria, you're.
It is what it is.
What do you mean it is what it is? You're bad advertisement for me. How can you be my producer and have saggy eyebrows? We're going to have to talk about this.
To tell the truth, I had not noticed it until I saw it in the picture.
All right, well, we can fix it for you. Don't worry.
Okay, so the next one is from Shamira _1997.
Shamira _1997. What do you think? You think that's when she was born, when she graduated?
This is she was born.
Okay.
Would you be able to brief on an areola reduction? I'm only 25. I've lost a lot of weight here.
Okay, so areolar reduction. So its own entity. First, you need to know a little rundown on anatomy of that area. So the areola, which is almost always called the nipple, people mistake these items. The areola is the pigmented part, the area of your breast that is pigmented. Some people have small ones, and small is around 30 millimeters. That's 3 centimeters. And many people have large ones, 60 centimeters, 70 centimeters, 80 centimeters. That's 6 to 8 centimeters. When your breasts sag or you breastfeed, as the skin relaxes and stretches and your breasts start to sag down, you start getting expansion of that areola, and therefore you see that your areolar size is large. Now, when you do a breast lift, a breast reduction, whether you want it or not, your areola, aka the pigmented part, not the nipple, which is prominent, sticking out, your areola will be reduced, meaning the size of it will be made smaller. But you can get an isolated areolar reduction unrelated to anything else, which is, hey, I love my breasts, they're amazing, everything looks great. But my areola relative to the size of my breast is pretty big. You know, aesthetically, if you have a B-cup breast, which is not that big, and you have like huge areolas, meaning pigment, most people don't love that. Nevertheless, you can reduce the pigment of your areola by itself, as opposed to just doing it into a reduction. And what it entails is going out around your areola to the edges of it, cutting that out, and then making a smaller areola inside, and then taking the intervening pigment that's extra out, and then closing it like a donut.
Now, what happens if your pigment is very pale?
Then you probably won't even notice that your areola is so big. It's usually concerning when you have a very dark areola, but the surgery is no difference whether you have dark areolas or light areolas. It just usually darker areola people bothers them more.
Okay, got it. because the pale ones, you can't really see them.
Yeah.
Right?
So, I mean, you don't even care.
Doesn't matter. Yeah, that's true. Okay. The next one comes from Kristen H4.
Kristen H4.
I have a small, flat pancake breast. What can I do?
I have a small, flat pancake breast.
Mhm.
Okay. Well, there's two things that make breasts pretty. This is universal, by the way. This isn't Dr. Raban's opinion. Because I love when people are like, well, everyone's breasts are pretty. I always get so heated when everyone's trying to be PC or socially correct. When we flip through a magazine, we don't care if it's Asian or Black or Somalian or whatever, what makes a breast look pretty and youthful is there's a shape to it and there's a size to it. And there's a youthful shape. And a youthful shape is as follows. There's fullness in the upper pull, meaning at the top of your breast, you have some fullness. The amount of contact between your breast and your chest is limited. Your breast isn't sitting on your chest. The shape of your breast is not a U shape, but a round shape. Your areolas are not at the bottom of your breast, but in the middle of your breast. And your areolas aren't ginormous, but relatively smaller. That's the shape part. No one in 20 years has come to my office and said, Dr. Raban, how you doing? Great. I'm really looking for a flat, saggy breast. Is that something you can help me with? Everyone comes asking for a youthful breast. So that's universal. The component that's variable, which is preference-driven, is the volume. Some people like youthful small breasts, and some people like youthful fuller breasts. So volume, how big it is, has some preference-driven aspects. However, if you want pretty shaped breasts and you don't have a lot of volume and your breasts are pancakes as described by this young lady, then you might need volume in addition to reshaping. So the answer to your question is you are likely, from your description, needing a lift, hence creating pretty shape, and likely needing an implant in order to add some volume. Lift for shape, implant for volume. Now, you don't need to be huge. You don't need to look like a porn star. All that is nonsense. You need to do it elegantly and classy, just like all the photos on my gallery. But you can't escape shape and size because that's what makes it pretty. Yeah.
Okay, so we're going to go on a quick break.
All right, we made it to the halfway point. We're going to take a break.
Yeah, and we're going to talk. When we come back, we have some more breast questions. There's also a question on pubic lift.
Pubic. I know you like that one because you're like,
Yeah.
pubic. I'm so curious.
No, but it's questions that you don't really hear very often, so I'm curious. And then, and some more questions on tummy tuck.
All right, great. All right, guys, we're going to take a quick break. We'll be right back to continue with your question and answer session on Plastic Surgery Uncensored. All right, guys, welcome back to the second half of Plastic Surgery Uncensored. Q&A, me, you, and Maria. We're going to dive into the second half questions. All right, Maria, what's next? What's next on the docket?
Okay, so the next one is from Zine B_Bound.
Zine B_Bound?
Uh-huh.
Okay, what's the question?
The impact of breast augmentation on a pregnant woman.
The impact of breast augmentation on a pregnant woman. Okay, pretty good question. So, I guess the question is, I have a breast aug, and I'm getting pregnant, and how is that going to impact me? Is that what you get it as?
Mm-hmm. That's why.
So the answer is the impact is as follows. Number one, your breast implant is not in your breast tissue. Your breast implant is under your breast tissue. In other words, it's not like it's mixed in there and now your baby's going to eat your breast implant. This is something that people used to inquire when they didn't have a good understanding. So your breast implant is either underneath your breast tissue or underneath your breast tissue and your muscle. So it's either under the muscle or under the gland, but it's always not in your breast tissue. The only place that it can really impact is depending on how the surgeon placed the implant. So there are 4 ways that implant can enter your breast and 3 out of the 4 of them don't have any impact on breast milk. Now, I only do 1 of them because I think the other ones are shitty. But the bottom line is that if your surgeon places the implant through your areola, that's right, the bottom part of the pigment from 5 o'clock to 7 o'clock, which, by the way, I did for many years, then you are going through the gland, you're going right through it to get to the pocket. And as a result, some, albeit not a lot, of the glands are being cut. And in theory, it will impact your ability to breastfeed. Now, you may make so much breast milk that it makes no difference that, 15% of the ducts are cut. You may have made no breast milk, and so it doesn't really matter either way. But for sure, a handful of those glands are being transected, and they don't just grow back together. The way that I do my breast augments today and have for the last decade is I go underneath the breast and in the fold. And the reason I do so is because I want to go right underneath the gland and bypass it. So I have nothing to do with your breast gland, whatever. So if you're going to make milk, you're going to make milk. You don't, it has no impact. The only thing that you might find is that when you get pregnant, your breasts get engorged and they get really full of milk, and the nipple opens up because milk is going to be coming out. And when you breastfeed, your child is suckling on that nipple. And so there's an exchange of milk and bacteria and all that stuff. So the implant is sitting in your breast with a capsule around it. That capsule is normal. Everybody has it. It's a little scar tissue. Some women, as a result of breastfeeding and getting engorged and pregnant, they get capsular contracture, aka hardening of their breast, because the capsule gets inflamed from the bacteria that comes in and out. Not dangerous, won't kill you, won't impact your child, but it may kind of annoy you because it affects the shape. And then be certain that when you're done with your breastfeeding, chances are your breast will never look the same. Not because the implant isn't good, because your tissue now is starting to sag while the implant stays behind. So many women get their breast augments when they're young, love it, looks great, amazing, da-da-da-da-da. Then have kids. I suggest have all your kids, do all your breastfeeding, and then do some type of revision to make it look pretty again.
Okay, the next one comes from Renault_store.
Renew_store. All right, that sounds like the car Renault, but I like that. Renew. Okay.
I've had 2 breast augmentations and both of them have bottomed out. Help. What does that mean? Bottom out.
Well, it depends. There's different meanings to bottom out. It's a general lay term. It doesn't necessarily have exact meaning. So I'll make 2 assumptions. So what does it mean to bottom out with breast surgery? There are 2 meanings to bottoming out. One is that the breast fold, everybody has a fold. That's the part of the breast that's underneath that the breast sits on. So sometimes when a surgeon puts an implant in, they violate, they ruin that fold and separate the connections. And then when you put the implant in, the implant, rather than sitting on the fold, in the fold, slides underneath the fold and pulls the fold off. And you get something called a double bubble, where the implant sits too low and it sits like on your chest rather than in the breast. Then patients call that bottoming out, meaning the implant is going to the bottom. That is one type of bottoming out. The other type of bottoming out is that my fold is not touched, but from my nipple to my fold is skin, and it holds, that's the hammock. The bottom of your breast is holding the implant. So if you pop an implant in, technically the implant is sitting on the skin that goes from your fold to your nipple. And in some people, and it's usually with really big implants, too big, causes that weight. The weight causes the breast to fall down and kind of look like a rock in a sock, meaning it falls to the bottom of the breast and then it doesn't fill up the chest and it's sitting really low. So depending on what version of bottoming out you have, there are different solutions. Now, I can't speculate here, but they're both difficult problems to correct and require someone who does a tremendous amount of revision work rather than just regular old work. Unfortunately, many patients who have bad outcomes go back to their same surgeon for the first correction. Naturally, they know you, they did it, they'll give you financial break. So when people say I've done it twice, it's usually not with one guy and then another guy. It's usually with the same guy. So, well, the first guy didn't do such a great job, so it doesn't really surprise me that this. You understand what I'm trying to say? So, to answer her question, I'd have to see her. But those are the two versions of bottoming out, both of which are no bueno.
And what can she do?
It's a long story to explain. One of them, you have to repair the fold. You have to fix the part that detached. And one of them, you need to remove some of the excess skin and downsize the implant because the tissue is unable to hold it. There is a third option, too complicated for this conversation, which is you bring tissue in, a third type of tissue. It's called extracellular matrix. It's like human skin or pig skin, stuff that the cells have been removed, and it's like a mesh, and it's not a mesh, but it's like a mesh. Mm-hmm. And it helps support the tissue, but it's super complicated discussion not to be had on our Q&A.
Well, we had an episode at the end of last year called Everything About Breast Implants.
Right.
That was in November of 22.
Yeah.
If they want to hear more questions and
November of 22, we dove more in depth in this topic. Okay, we're great. That's why you're the producer.
That's why if they want to hear more, they can go there.
All right.
Question comes from Maya Hill 112.
Maya Hill 112, fire away.
3 weeks in after flank lipo and abdomen lipo, surgeon drained 800 milliliters.
Yes,
and I looked the same.
And I look the same. So why are we answering this question? Why? Because I've recently been on a tear about liposuction. I've posted all this shit on social media, and it's been interesting, the responses. So why am I talking about this? Because this is the classic situation. A patient writes in that says the following: I'm 3 weeks out. My surgeon removed a boatload, because in my opinion, 800 is a lot. 800 cc's from my love handles and my belly, and I don't look any different. So my answer to her is, just you wait, because you are now swollen, and what you think is or isn't happening changes dramatically over the next few months. And what usually happens is as the swelling goes away and you start to shrink, so do begin the problems of irregularities and ripples and divots and loose skin, etc. So I can't tell you how much you needed, how much fat you had. All I can tell you is 3 weeks is not even close to time frame from which you can make any kind of assessment. You cannot put a souffle into the oven and 3 minutes later open the oven and be like, this thing's not ready. It tastes like caca. Yeah, it's not even close to ready. So you got to wait minimum 3 to 6 months to start to see results, and sadly 12 to 18 months to start to see complications. 3 to 6 months for things to look good, 12 to 18 months for things to start looking like shit.
No, I think that in our society today, we're so much about immediate satisfaction that 3 weeks to me doesn't seem like a long time. I don't know why you would expect to see an immediate...
Why? Why? Because you go online and you look at Instagram and people are posting pictures and they make themselves look like they were SpongeBob, and then they had surgery and now they look like Jessica Rabbit. Oh. And it's like, oh, I'm only 1 week out. Haven't you seen the on-table results? Like when surgeons show the patient all propped up, pillow underneath their hip, all narrowed out, like they make you look like it's like you're so snatched. So patients are disappointed.
Sucks. But anyway. Okay, so my next question, which I like, is from Mrs. and it sounds like it's or Mr. Smack 2018 or Mrs. Mac 2018.
I'll go with Mrs. Mac instead of Mr. Smack. Okay.
Pubic lift, is that a part of a tummy tuck automatically?
Oh, God, you've been waiting for this for almost 40 minutes now.
Yeah.
Pubic lift, is that part of a tummy tuck automatically? Great subject. As always, we begin by definition. What that beep is a pubic lift. So, the normal human anatomy of the trunk is that you have your abdomen, the belly button, and then you have a normal fold in most patients, and then you have your pubis. Your pubis is the part of the front edge of your body that underneath which is your clitoris, your labia, your introitus, your vagina, etc. So the pubic area is the bottom part of your abdomen over your pubic bone. Another term for it is your mons, M-O-N''S. Pubic or pubis and mons are the area in your private area that you wear your bikini over. Now, many, many patients who have babies and lose weight develop alterations, changes in the pubic area alongside their abdomen. And what are those changes? Two things. One, I have loose skin. Surprise! If you have loose skin in your abdomen, you're going to have loose skin in your pubis. They're neighbors. They're connected. And the second is trapped fat. It's a fupa. It's full and it's puffy and it's got fat trapped in it. And I never had this when I was younger. The third is if you had a C-section, now you have a scar that's got a dent in it. So you have a dent with loose skin and fat in it. So when you go get a tummy tuck, there's a large incision in a fold in your natural crease is what most surgeons do. And then they operate northbound. They go upwards. And they go and do your belly button and da-da-da and repair muscles and da-da-da, and they pull down and they suture it closed. Some surgeons will offer you liposuction of your pubic area in conjunction to your tummy tuck, which only makes your pubic area worse. The worst thing you could do is try to liposuction your pubic area. Why? Because the fat in your pubic area is totally different than the fat in your love handles. The fat in your love handles, the fat in your back, the fat in your thighs is regular fat. The fat in your pubis is fibrous fat. It's connected. It's very rigid. So when you try to liposuction it, you make a boatload of irregularities because it doesn't want to come out normally. So the pubic area often is left very sort of unsatisfactory. You do this tummy tuck, looks pretty dope, and then they connect you to this kind of fudgy-wudgy pubic area. And then are you happy now? Not really. Like, yeah, sort of. I mean, I guess I could wear that dress now, but I don't really feel like wearing a bathing suit, and I sure as hell don't want to be naked. So when I do a tummy tuck, every single tummy tuck has a pubic lift and a pubic rejuvenation. So again, I make my incision, and rather than going north only, I go south. And I literally lift up the pubic area, lift it up, dissect it, open it up, and I take a big wedge of the excess fat that's redundant and accumulated, so you're not so puffy. And then I lift up the pubic area, and then I remove the excess skin. So you're getting a rejuvenation of the pubis as well as a tummy tuck, so that when you connect the two and you stand there naked in front of the mirror, your abdomen and your pubis look one and the same. They're the same part of your body, as opposed to abdomen, scar, pubis. So I can't speak for other surgeons as to whether or not they do it, they don't do it. You have to ask for it. It's extra. I don't know what they do. For me, it's standard every abdominoplasty. I do a pubic lift irrespective. And the reason being is you'll never get a good abdominoplasty if you don't do it. So that, Maria, is a pubic lift.
I've learned a lot.
You learned a lot today.
Okay. So our last question.
Last question. All right, guys. What's the last question?
Is from Ben Rebel.
Ben Rebel or Ben? Yeah.
Rebel.
B.
Are there risks with the tummy tuck after hernia repair with mesh? Do you remove mesh?
So this is a tricky question. I do a tremendous amount of complicated revisional abdominoplasties with hernias and severe DR and whatever. So let me give you my thoughts. In general, mesh is very difficult to remove because depending on the type of mesh, and there's tons of different variations of mesh, it often gets incorporated or scarred into the area it's placed. Imagine a fishing line or a net or something. It's not something that's easily removable. The second thing is it depends on what type of hernia and where the mesh is. If your hernia is from a colostomy and there was a hole there and it's to the side, we're not going to mess with that. If your hernia is midline, down the middle of your abdomen, because you had a hernia from a belly button or whatever, if I can't remove the mesh, which I try to in the midline, then when I go to repair your muscles, which is 90% of patients, I bury the mesh down under your muscles as I repair them over the mesh. Again, mesh outside of the midline, down the middle, I don't mess with that because it was there for a reason. Somebody did something. Mesh that was placed in the midline, in my opinion, should never have been placed. What you needed done was for your muscles to be repaired, which would have served as a biologic mesh. And if I can't remove the mesh, I just bury the mesh under your own muscle. And I've never really had an issue operating on people who've had previous mesh placed in. It's not fun. It's not an easy surgery. Of course, it makes things more complicated, but certainly not prohibitive. In other words, oh, I had it, so I'm not a candidate. No, not the case. You won't go to your garden variety guy, but guys that do a lot of this should be able to manage it.
Okie doke. Well, that's the last one, but I wanted
That's a wrap?
That's a wrap, but I did want to do the comment that...
You found it? You found our positive reviews?
I started looking for it and I started playing the podcast and everything was going crazy. But here, this one was recently posted and said...
Recently posted what date?
Yeah.
What was the date?
It's last Friday, so it would have been the 21st.
Sometimes it's... Oh, got you.
Okay. It says here, such a great listen. I've learned so much from this podcast. Thank you, Dr. Raban, for sharing your knowledge with the world. I think anyone considering going under the knife should listen to this podcast.
Well, that's lovely. It's always nice to know that I'm sitting here on a Sunday ranting and raving and making all kinds of... and somebody's appreciating.
I've learned a lot especially from today's.
What did you learn? You learned that you need your eyelids done. That's what you learned.
Well, that I knew a long time ago.
You just said you found that out when you went to the driver's license.
Yes, I just found out about it is what I'm saying. I didn't. The other one says, honest and clear in form. So refreshing. I've learned a lot from from the doctor. This is a wonderful podcast. Thank you.
Amazing. We love you.
Really
all right, guys.
Rabat.
All right. So this is another wrap of Plastic Surgery Uncensored. Hopefully you enjoyed the show. As always, my pleas at the end and now at the beginning. Number one, if you enjoy our show, download, subscribe, share. This is how we keep alive because you guys are spreading the news, and the more following we have, the more power the show has. The second is, listen, everybody wants to hear something nice every once in a while. So if you like the show today, go write something right now. Go share your thoughts. That makes Maria, me, all the people that are post-production, pre-production, everybody gets a kick. At any rate, until next time, that's a wrap. As always, a pleasure. I'm your host, Dr. Rady Raban. We'll see you next week on Plastic Surgery Uncensored.